Your carbs are not your enemy at all. We need those glucose going. We need those glucose to fuel our brain, our blood cell, and everything. Rather than saying a word cure, I think I would prefer having cure means it's completely eliminated. I don't think it's going to happen once you are a diabetic, but I like to put it as a word called remission. Yes, so one of the absolute good advancement in diabetics, I will say, is CGM. It means continuous glucose monitoring. It's a wearable, it's a technology where we wear the sensor and it automatically reads your blood sugar. Patient doesn't have to poke them anymore. Day and night, 24/7, it keeps on monitoring the blood sugar. Like, they're amazing. They're one of the major advancement, I would say. And people are running crazy after it, right, left, and center. I'm also a huge fan of it. It helps for diabetes control. It has the benefit of weight loss, controls the cardiovascular complication. It's protecting kidney. It's amazing. It's Ozempic plus Mounjaro plus a glucagon inhibitor. So it's going to be massive. And again, another thing I tell everyone, it doesn't matter which part of world we go, our genetics will follow us. Let's say obesity not only doubles the triples, but there's a research showing quadruples the risk of being diabetic. So this is a myth that only overweight people would be diabetic.
Is sugar really the reason people develop diabetes, or has it been misunderstood all these years? Continuous glucose monitoring, glucose spikes, and Ozempic. Conversations that have taken over the world of diabetes and beyond. But here is the problem. People who actually talk about blood glucose do not really understand how diabetes works. I'm your host and welcome to Myths to Medicine. On today's episode, I'm joined by Dr. Pratikshya Thapa, an endocrinologist and assistant professor of medicine at University of South Florida. She is also the medical director of adult diabetes program at USF and Diabetes and Endocrinology Center. Thank you, Dr. Thapa, and welcome to Myths to Medicine.
Thank you so much, Asma. Thank you. It's my absolute pleasure to be here. Thank you for the opportunity.
Thank you again for joining us. We really appreciate it. Now let's dive into the questions.
Sure.
So the first question that we have here is, why are so many young people developing diabetes today?
Mhm. Two types of diabetes to begin with, type 1 and type 2. Talking about type 1, it's an autoimmune condition, meaning your pancreas is considered as an outsider by your own body, so it's attack it. So for type 1, I would say there has been modest increase in rate, but absolutely for type 2, we could see statistically the numbers of type 2 diabetes is rising. So definitely talking about here in the United States, I would say under the age of 20, diabetes, the rate has been at least, I would say, doubled in last 10 years. And let's talk about all the young teens, 1 out of 3, they are pre-diabetic. And globally speaking, the data says that from 1990 to 2021, the type 2 diabetes rose close to 94% worldwide. This is like extremely concerning finding. Say, if I have to pin the reason, I think it's basically because of the poor diet, number one, because we do a lot of increased sugary stuff, like increase in sugar consumption, more of processed food, decreased physical activity, like more focused on the screen time whenever they are at home, right? Less physical activity, and again, another thing I tell everyone is doesn't matter which part of world we go to, our genetics will follow us. If we had this genetic family history thing, and again, in utero, let's say if the mother has like had gestational diabetes, it is also one of the reason that in future the kid would develop diabetes. So overall, a lot of things asthma, but I would say definitely poor dietary adherence is one of the cause. Like type 2 diabetes is increasing.
Okay. So we do have that's a multitude of reasons. It's just not one factor.
Exactly.
And what is, I hear that term a lot when it comes to diabetes. What is insulin resistance?
Okay. So basically, it's a condition where your blood cell, especially muscle, they do not respond with the insulin. They have so either not respond or shows very poor response. So let's say whenever we eat, after we eat like high carb food, our blood sugar would go up, and our pancreas will sense that, and they will release a hormone, insulin. It's basically it acts like a key. It will go and knock the door for the cell, and the cell will open the door and the sugar would go inside. Like When we had this poor dietary choices, like suddenly if we started having this insulin resistant, the door doesn't open, so the body is not responsive with the glucose. So in a way, like a pancreas thinks that, okay, the blood sugar is rising, it keeps on making more and more insulin, okay, but it doesn't get response. In a long term, the pancreas gets fatigue. We call it like pancreatic fatigue, and that's the term, like insulin resistant.
Okay. That is quite helpful to know. And thank you so much for explaining like that, like up to a 5-year-old. I would consider myself a 5-year-old when it comes to insulin resistance. I absolutely didn't know that. Thank you so much. Um, so moving on to our next segment, which we call as the myth busting segment. So
Okay.
we are going to present some myths to you that are, going on around in the diabetes world, and we want you to bust those myths, okay? So
Sure.
myth number one, only overweight people get diabetes.
Okay. So, no. So, this is not true. Okay. Of course, when I said in the beginning, obesity is one of the risks where there is predisposition, it causes increment in the risk for the type 2 diabetes. Let's say obesity not only doubles the triples, but there's a research showing it quadruples the risk of being diabetic. There's no doubt with more weight it causes diabetes, but it would I would say 75% or the 80% would be diabetic because of the weight. So what about the rest of those 20%, right? So I have had handful of patients who looks perfectly fine with their healthy weight and all, but they have this severe insulin resistance. So we call them something called TOFI. TOFI is the word. It's called like thin on outside but fat in inside. So there's something called visceral fat. Visceral is the internal organ. There is a fat deposition, and those causes that insulin resistance. Those fat, they metabolically they active and promotes the inflammation and contributes for insulin resistance. So this is a myth that only overweight people would be diabetic.
Okay, that's good to know. So, people like Dr. Thapa said, TOFI, please be careful. We just never know. Okay, myth number two, honey or brown sugar is healthier than white sugar for diabetes.
Oh, this is a good one as well. So I have a lot of patients. They come to my clinic and say, "Oh, Dr. Thapa, I have been listening to you. I've been cutting on my sugar, and now I have started using more and more honey." Like, well, like, and I was like, "Oh no!" So I'm glad that you brought this topic. So let's go like into detail of it. So I can begin with like white sugar. Of course, white sugar is a very much of simple carbohydrate. Let's give an example of 1 teaspoon of white sugar. So it has 4 grams of carbohydrate. If we go into calories, it's around 16 calories. Okay. So, and there is something called glycemic index. That means it's a rank that will tell whenever we eat carbohydrate how high our sugar would shoot up. So it has very high glycemic index. Okay. And similarly, let's if we compare with brown sugar, the same 1 tablespoon, it is even more. It's 4.5 gram of carbohydrate. People call it white sugar, sorry, brown sugar a little bit better because it has other thing. It has calcium, it has other iron and other supplements. So they call it healthy. But in terms of diabetes, calorie and carbohydrate, it has more carbohydrate and the calorie is also 19 gram. Okay. And coming to the honey, again, it depends on what kind of floral derivative it is of. Usually, honey has 6 grams of carbohydrate and it has 21 of calories. But the catch here is honey has less glycemic index, meaning if we consume honey, our sugar would not go rise right away, but over time, the effect is same. So this is absolutely false that brown sugar, honey is better than white sugar. It's one or the other. Of course, there are extra benefit, like example, honey has antioxidant property and all, but in terms of diabetes, they are no better than anyone.
Oh, that this is news to me, especially as a mom, when I am always giving honey to my kids, saying, "Oh, this is better," if you like, don't eat that sugar. It's honey is better. So that is good to know. Thank you. So myth number three: carbohydrates and sugar must be completely eliminated.
Completely eliminated. Okay. Again, busted again. This is a false statement, I would say. So I want to open my statement saying that your carbs are not your enemy at all. We need those glucose going, Asma. We need those glucose to fuel our those carbohydrates needed for our brain, for our blood cell, and everything. Completely stopping the carbohydrate, I think it's absolutely unnecessary and even unsustainable. I don't know about you, but for me, if someone say, "Hey, don't eat carb for a couple of days," I won't be happy at all. Okay. So the thing is, type of carb. Like instead of refined carb, we go with the natural one. So let's say instead of doing canned fruits, we can always go for whole food, oranges, berries, right? We can go with the vegetable, broccoli, and all. Like little bit go like avoid all those kind of like white bread, excess sugary stuff. Cereals you can do, but avoid the sugar coated cereal, like honey syrup kind of thing. And I always tell all of my patients, control the carb, do not avoid it. And my goal for everybody is I just tell them, do around like maybe 20 grams of carb for breakfast, around 45 to 60 for lunch and dinner. I am not talking about their proteins. They can eat 10 eggs, they can eat two salmons. I do not care. But as a diabetic, for the carb, the portion has to be controlled. So it's absolutely not necessary to stop or eliminate carb totally.
That is good news for all our carb fans out there. Okay. Myth number four, taking insulin means you failed. Is that so?
Mm. Again, no, it's a completely false information, I would say. American Diabetes Association, they have addressed this concern. They have put in one of their section, they are saying that needing insulin doesn't mean you failed, okay? Because type 2 diabetes, again, type 1 is different story, Asma, because type 1, the body is attacking the pancreas. There's no insulin. They have to be on insulin from day one. Of course, there is a honeymoon period where they can produce a little bit here and there, but eventually, yes. But for type 2, it's a progressive disease. Doesn't matter how good you are into your diet, how good you try, like eventually over the time, the pancreas will lose some function and they might need help from the insulin. So there was an excellent trial. It was done in UK. It's a UK prospective diabetes study. It was a randomized control trial. They included 5,200 people from the age of 25 to 65 years. And they did a good study on them for good 20 years. From 1977 to 1997, they followed them for good years and they had them on intensive lifestyle therapy with all the medication. And after that, their diabetes was much controlled. But after 20 years, they did a secondary study called legacy study, and they followed up on a lot of them, and they noted that handful of them did need insulin. So this research made a core concept that yes, despite of whatever we do over time, there's a thick chance that we might need insulin supplement. Okay. So I always tell my patient like needing insulin is not a failure. You did nothing wrong. It's just a biology. Your body could not take it and just you have to just accept it. And then I'm been glad that insulin has been out. Like it's been so many years. It's a safe medicine. At least we have options. That's what I keep on telling my patient. And absolutely, this is a false statement that if you take insulin, you fail.
Mm, exactly. And so that's also good to know, because I we have family members who actually get scared about the idea of just having insulin
Correct.
in their
Of
body.
course.
So I'm definitely going to share this with them.
I have a prime example. My dad is a diabetic. So I've been telling him he's been diabetic for like 20 years now. And I tell him it's just about time, maybe sooner or later you might into insulin. Like, he thinks that if he ended up someday with insulin, he failed himself as a diabetic. So yeah, it's a renowned myth. So
And myth number five, weight loss drugs like Ozempic can cure diabetes.
so again, it's such a common concept going on these days. Patient come to me and say, Dr. Thapa, I had a family member or somebody where I work. I saw that patient literally shrink. That person is losing weight, didn't go for surgery, and diabetes got cured. So I want to be on those medicines. So what are your thoughts on that? So it's going on because of the all GLP-1 agonists like Ozempic, Mounjaro in the market. Rather than saying a word cure asthma, I think I would prefer having cure means it's completely eliminated. I don't think it's going to happen once you are a diabetic, but I like to put it as a word called remission. It does decrease your chances of like having cardiovascular complication. It will reduce it has been highly effective in management with the blood sugar and all. So I would say the signs and symptoms will definitely disappear, but let's say god forbid they ended up into stressful situation, they were not compliant with their medication and diet, things will come back again. So I don't think this statement, this is again a myth, I don't think it's true. It will cause the remission, but I would not say cure.
Thank you. Thank you so much for explaining that. Um, Now, moving on to our third segment would be the future of diabetes. Okay.
Mhm.
So, as you're an endocrinologist and you see a spectrum of diabetes, every day, um, I, the care of diabetes, it has evolved rapidly in the last 10 years. It's definitely not like what it used to be 10 years ago.
Definitely.
We now have devices that can track blood glucose 24 hours a day in real time, which is called continuous glucose monitoring or
Yes.
CGMs, right?
Yes. Yes.
So for our listeners here, can you explain how does it work? And do you think they're going to be as common as like smartwatches in future?
Yes. So one of the like absolute like good advancement in diabetics, I will say, is like CGM. It means like continuous glucose monitoring. It's a wearable, like it's a technology where we wear the sensor and it automatically reads your blood sugar. Patient doesn't have to poke them anymore. Day and night, 24/7, it keeps on monitoring the blood sugar. I do have a sample here. Again, like I'm not promoting anything, so I just kept the cover outside, but this is one of the popular CGM device. You get it in the market. It comes with a sensor, there's a transmitter, and a receiver. So we wear it at the back of our arm. That's the FDA side. We ask our patient to do there. So basically, it's when we open it, this is the sensor, okay? And I'm not sure if you could see it. Let me put it a little bit. There's a small thin filament in here. It's like a stand of our hair. We call it sensor. It gets the blood sugar reading from the interstitial. We don't do it directly from the blood. The reading we get it's from an interstitial, meaning it's in the cell area where the blood flows. And this sensor has an enzyme called hydrogen peroxide. When the blood flows there, it changes into it changes into hydrogen peroxide and it releases the amount of sugar. Okay, so the sensor sends it through a transmitter, and we have a receiver. Receiver can be something the company gave to read, or it can be inbuilt in the smartphone. They don't have to scan it, that their number will directly go there. So it's an amazing technology. They don't have to poke their finger. But keep in mind, this sensor, they read it is from the back of your arm in the interstitial fluid, not from the tip of your finger. So this is the real time, but this one, there's a lag of at least, I would say, 5 to 10 minutes. So the reading you are getting from this could be like 10 minutes, 15 minutes back. So there could be a discrepancy of 15 to 30 units. Okay. So if somebody asks me which is reliable, of course, the real time finger stick is reliable, but the sensor is also, it's good. So moving to your second question about the smartwatch and all, yes, I definitely think like it's actually being much and much popular. People are like running crazy after it. Actually, our American Diabetic Association, they have like made a disclaimer already that if somebody is a diabetic and using at least one form of insulin, they need to be on sensor. We have already recommended it, and people are getting more and more conscious about this diabetes, pre-diabetes, and they wanted to try. For those people, they don't even need a prescription. The one of the company has released over-the-counter continuous glucose monitoring so that they can just wear and see how the numbers are. So I honestly don't think it will surpass the craze of the smartwatch because the smartwatch is like next level, but definitely it's going to be pretty common like that.
Okay. So you mean to say, like, piggybacking on your question, so even pre-diabetics or people who have no diabetics at all who have no diabetes at all, can they use this as well? Do you think it would be helpful for them?
So they can, and helpful as in what I say is like, again, I was asked this question different times by my patient as well. Like, my dad is a diabetic, he's wearing a sensor. Should I be wearing it? So, my question would be, if you are pre diabetic, not because the name itself is there, you are not diabetic, you are pre diabetes, you're not taking any medicine. So, if you want to use it for an educational purpose, yes. So, let's say at this age, at least for me, I have reached in some point of my life that I don't go out and experiment new food every day, right? So if they wear it, let's say for a month or 2 month or 3 month, they would know that what kind of food make their blood sugar go high, how high, and how long the sugar will come down to normal. So in that way, it will incorporate in their mind. So they will learn to do a portion control. Just for an example, let's if we go to somewhere there is a monitoring by a camera, people will behave like little bit better than others. That's a human nature. That's the same thing. If you wear the sensor, they will be aware and they will know that this food is good, this food is not. So for pre-diabetic, I would say just to learn that thing. If they want to wear for a couple of months, it should be fine. But in a long term, I don't think so. It's like cost prohibitive, right? You have to wear it all the time. Sometimes could be discomfort. So I do not recommend all the time. But if they want to learn things, use for a motivational purpose for a while, why not?
Absolutely.
Mhm.
No. Thank you. So moving on, like as we just spoke about you a little while ago about the Ozempic. Another big conversation happening in medicine and is often hailed as revolutionary in the world of diabetes is drugs like GLP-1, including semiglutide and Ozempics.
Mhm.
What is your take on that? Are they the future? And what do you think?
I mean, like they're amazing. They're one of the achievement that's one of the major advancement, I would say. And people are running crazy after it, right, left, and center. I'm also a huge fan of it. It helps for diabetes control. It has the benefit of weight loss, controls the cardiovascular complication. It's protecting kidney. It's amazing. But I would say just not only the future. There's a lot of thing happening in the background. I would say it's not the singular future, but definitely one of our biggest achievements. So, for example, there's another call with a lot after Ozempic. Ozempic was released around 2017, and there's another Mounjaro. It's along with GLP, it's a GIP agonist as well. It is more aggressive than that. Mounjaro is getting more and more popularity, and there are two more exciting drugs coming. They're hoping to release it in the mid of 2026. One is known as CagriSema. It's a GLP-1. Plus, it acts on the amylin receptor. And another is called Retratutide. It's GLP, GIP. It's like Ozempic plus Mounjaro plus a glucagon inhibitor. So it's going to be massive. So people are like eagerly waiting for that drugs. Okay. And again, there is another group of people saying that, okay, so we did multiple injection a day, we have come down to a weekly injections. Why not to go for orals, not poke at all, right? So there are a lot of orals, semaglutide as well. Rybelsus has been on market for a while. Lilai Ili, they recently, in this early January of 2026, they released another like a tablet. It's called Orfoglyphosine as well. It has also proven very good benefit like the injection. So they're evolving towards the injection as well. So these are all the finding for type 2. For type 1, there's different story. People are doing a lot of invention in case of like insulin pump. Again, asthma, it could be maybe like another series of podcasts. I would say I can go on again and again. But again, for type 1, we have like insulin pump. They are doing a lot of like the stem cell transplant. So many advancement. Yes, definitely GLP-1 has opened an opportunity, but I would say like there are more in the future.
Wow. But that was a wealth of information about all these medicines. Thank you.
Mhm.
I absolutely enjoyed listening to that, and I'm excited about the future of diabetes. It is exciting. So now moving on to our last segment. So let's, key takeaways, which we usually do. That's our last segment for our podcast.
Mhm.
When should someone get screened?
For diabetes, screening is like again, like at first things has been changed for the screening part also, I would say. because our first question was diabetes is being seen in even in the early age, right? So ideally, if someone doesn't have like any risk factor or anything, before, what we used to do is after 35-year old, we used to screen for diabetes and repeat it every 3 years if everything is normal. But now things has changed. We can screen. The recent 2026 ADA guidelines says we can screen for diabetes at any age if our BMI is high. By high, it's if it's more than 25, and it's a little cutoff for ASEAN like us, like it's like 23, plus one of these risk factor. By high risk factor, they meant if they have a family first degree related with diabetes, if somebody has a PCOS, if someone has a cholesterol issue, especially the HDL, good cholesterol is a low number, or if someone has PCOS, uncontrolled blood sugar, blood pressure, so for them we can screen anytime. Or let's say if there is somebody who is pre-diabetic, we need to screen them for diabetes every year. So that's the guideline.
Oh,
Basically,
so
it's saying like screen everybody. I would say.
right. So I was just going to say, like, my dad was diabetic, but my BMI is normal. I would, but as a precautionary measure, I should still go and get myself screened.
If your BMI is, again, we are Asian, so if your BMI is less than 23,
Hmm.
you don't have to worry. But if it's 23 and more, and your dad is a diabetic, definitely you need to go and screen once.
I need to check my BMI then. Okay. The second thing is, do you think diabetes is preventable as it's preventable or it's non-preventable at all as we age?
Uh, I would definitely say, as we age, again, the risk of the diabetes keeps on climbing up as we age because we keep on losing our muscle mass and our insulin sensitivity will decrease as we age. But it's absolutely preventable. There was a huge trial like DPPP trial. We call it landmark trial. It actually nailed the landmark for diabetes. Like they did a intensive lifestyle changes on a group of people, and it showed that it significantly decreased the conversion, like the development of diabetes. So what we recommend to all of our patients is good lifestyle, okay, good physical activity. By physical activity, we would say at least more than 150 minutes of intensive exercise, be it like brisk walking, cycling, swimming, over a period of a week, more than 150. Good sleep, I would say more than 7 hours a day. Very much little bit consumption of alcohol, limitation on alcohol consumption, no smoking at all, diet wise, Mediterranean diet with low glycemic index. These are the key points. If we could do that, I would say definitely it helps a lot. It helps a lot.
Okay. So, okay, now, which my our last question for the day for this podcast, I think it would somehow tie down to what you just said. Um, can we can we control diabetes without medication?
So again, the same thing.
Right.
The behavioral wise, those are the same thing I mentioned. But the question here is diabetes at what stage? So let's say somebody comes with a diabetes with like HbA1c is something that will tell how control has their sugar been in last 3 months. So if the HbA1c is very high, they are already poorly controlled and they say, hey doctor, I want to do just a lifestyle change without medication. Can I control it? It will be absolutely no. But let's say if someone has just diagnosed a little bit more than pre-diabetic, but definitely diabetes, yes, we can, based on whatever I said, good physical activity, exercise, sleep, and diet, they can. But with the uncontrol, there's no way.
Okay. So there we have it, folks. I mean, it really depends case by case and, individual wise. So we can't just have a blanket treatment for anything.
Exactly.
Right. Okay.
One
Thank
size
you.
doesn't fit everyone, right? So it has to
Right,
be
right. Yeah.
individual.
Not
So.
blanket treatment. Okay, thank you so much, Dr. Thapa, for joining us today. We really appreciate it, and sharing your insights. We really appreciate, it was very enlightening discussion.
Oh, the
And for the
pleasure.
folks out there, um, you know, diabetes is a journey. Every small step counts. And if you need help and support, please do not hesitate to reach out.
Absolutely. Very well said, Asma. And pleasure was all mine. Thank you so much for giving me this opportunity. And your podcast, I just want to give another minute saying that I cannot thank you guys enough. You, Bibushan, Dr. Basmit, you guys are doing such a good job. This e-healthy info, the whole team has done just such an excellent job on breaking all those complex health topic and helping out like the broader in the community. Or it's so much simple. I have had heard like couple of your podcasts, so informative. And we go like we have a history, we go a long time, and seeing you guys doing such a good thing, it gives me such a I'm so proud of you guys. Thank you
Thank
so
you.
much.
It really means a lot. It really means a lot. Thank you so much, Dr.
Thank
Thapa.
you. All righty, see you.